Good afternoon, everyone. I'm going to be talking about pulmonary complications of liver disease. I have absolutely no disclosures. So we can divide it into three groups: lung parenchymal disorders, pleural diseases, as well as pulmonary vasculature. I'm going to be focusing on hepatic hydrothorax and hepatopulmonary syndrome today. So when we look at lung parenchymal disorders that can occur in patients with chronic liver disease, emphysema in patients with alpha-1 antitrypsin, when they have the pan-acinar emphysema, pneumonia, be it in patients with hepatic encephalopathy, they can have an aspiration pneumonia, and organizing pneumonia in patients with primary biliary cirrhosis. I'm not going to be talking about portal pulmonary hypertension today because it's vast, and we had a lecture about 6 months ago. So our objectives for today is going to be identify hepatic hydrothorax, hepatopulmonary syndrome, and using the most recent guidelines for its diagnosis, and to understand the pathogenesis of both these disorders, and to look into the treatment options. There aren't a whole lot of studies. It is a little bit of a dry topic, and most of the studies that were done are in 2004, in early 2000s. So to start off with hepatic hydrothorax, we all know portal hypertension is a well-known complication of liver cirrhosis and end-stage liver disease. The most common manifestations are ascites and variceal hemorrhage, which we see. They develop in about 47% and 37% respectively. Hepatic hydrothorax is actually a diagnosis of exclusion. It's defined by transidated pleural effusion in patients without any cardiac or underlying cardiac, pulmonary, or pleural disease to begin with. And these patients usually have portal hypertension. The incidence is low. It's because of the fact that most of these patients are asymptomatic and not everybody gets tested. So it's 4 to 6% in studies that use chest x-rays. And it's not a common complication of liver disease. The prevalence is only about 5 to 10% in total. Hepatic hydrothorax accounts for only 2 to 3% of all pleural effusions. Most of the effusions are predominantly on the right side, and 20% can occur on the left side, and bilateral about less than 3%. So the pathophysiology of hepatic hydrothorax, similar to ascites, where there is loss of protein and fluid extravasation into the extracellular space. The similar concept, however, what plays an important role is there's a theory that fluid gets shifted from the abdomen into the pleural cavity via diaphragmatic defects. And this has been demonstrated by injecting air into the abdomen. And the patients underwent an X-ray in 5 minutes and 24 hours after being injected with air, and they were noted to develop a pneumothorax on the right side of the chest wall. And in autopsies, they demonstrated diaphragmatic defects in patients, and these were just not cirrhotic patients. This was just a general population, and they described it as 4 different types. Unfortunately, I don't have any pictures to explain it better, but type 1 is when there's no obvious defects. Type 2 is when there's blebs lying in the diaphragm. Type 3 is fenestrations in the diaphragm, and type 4 is multiple gaps in the diaphragm. Microscopic exam of these defects has shown that there's discontinuities in the collagen bundles of the tendinous portions of the diaphragm. So this is a scintigraphic study where they injected technetium into the abdomen, and 24 hours later, they had noted that there was evidence in the left pleural space. So most of the defects do occur. Most of the effusion is on the right side, and it's because of the close proximity of the liver and the diaphragm, and the fact that there is negative intrathoracic pressure. Think of it as a piston where fluid just gets sucked in. But this doesn't really happen on all cirrhotics, so it is a very rare complication. 20% of non-cirrhotic patients, the general population, do possess this weakness. However, the effusion doesn't occur because of the fact that the pressure in the thorax is higher than in the abdomen. However, when you have a patient with ascites, you can have fluid shifting into the pleural cavity. So when you have pleuroperitoneal blebs, there's been case reports where there's few cases patients presented with acute hypoxic respiratory failure because of acute tension hydrothorax, but this is not something that happens that common either. So usually patients have stigmata of chronic liver disease, and most of them are asymptomatic. However, they can present with shortness of breath, and it's usually progressive and insidious in onset. And we spoke about the acute tension thorax. And similar to spontaneous bacterial peritonitis, there's also a concept called spontaneous bacterial empyema or spontaneous bacterial pleuritis. We'll talk about that in the next few slides. So again, to diagnose a patient with hepatic hydrothorax, this patient must have portal hypertension, and we need to exclude the fact that they don't have any underlying heart failure or primary pulmonary disease that can cause the effusion or a pleural disease. The fluid analysis is transidative, and they looked into in 60 patients of cirrhotics. The pleural fluid analysis in about 40 patients was transidative, compatible with hepatic hydrothorax. The fluid analysis changes slightly in spontaneous bacterial empyema, which I'll talk about. And it's not really necessary to shoot a dye to confirm that this patient has a pleuroperitoneal communication, peritoneal pleural communication. So spontaneous bacterial pleuritis occurs in 10 to 16% of those with hepatic hydrothorax. They can present with pleuritic chest pain, fever, and encephalopathy. The only difference between the fluid analysis in hepatic hydrothorax and those with spontaneous bacterial pleuritis is they have a higher ANC level, more than 250 with a positive fluid culture, or an ANC level above 500 with a negative culture. And keeping in mind that these patients have not had a pneumonia or anything that can explain that underlying effusion. So a rough algorithm when patients who have pleural effusion demonstrated on a chest x-ray, apart from routine lab work, an echocardiogram can be useful to rule out heart failure, and a pleural fluid analysis. If it's less than 250, it's compatible with hepatic hydrothorax. If the ANC count is more than 250 with a positive fluid culture, then it's spontaneous.
Make sure. Can you have a spontaneous bacterial when you're not have a negative, don't have SBP? Like an infection in the chest that's not.
I don't know. So usually these cases are very, very rare, and there's only case reports of most of them. So there's not a whole lot of literature where patients have had both. I haven't come across anything where they've had both empyema as well as peritonitis.
So the answer is yes. So which is why that if they have someone with pleural.
Why'd you ask me that?
No, bring it up. Of course. So the answer is yes. If they have someone with a pleural effusion that's hepatic hydrothorax and SBP or ascites, you have to tap both because you can have spontaneous bacterial empyema, but you have a negative abdominal count.
So always, I was going to talk about tapping the chest. Usually, whenever you have a patient with hepatic hydrothorax, you'd want to do an abdominal paracentesis before you do a thoracentesis to ensure that, because if you do a thoracentesis and the fact that the ascites fluid is just going to keep mobilizing into the thorax, you can have repeated multiple procedures. So approaching treatment to hepatic hydrothorax, there's 4 ways to go about this. One is reducing the formation of ascites, which involves diuretics and dietary restrictions, preventing the fluid from crossing the diaphragm, and draining the pleural fluid within the pleural space and obliterating the space, otherwise known as pleurodesis. So medical management, which involves loop diuretics and aldactone, works similarly compared to as effective as patients who have ascites. However, there's a retrospective study where they looked into 40 patients, and about 20% of these patients had refractory hepatic hydrothorax despite aggressive diuresis. And the use of IV octreotide is not well proven. There is few cases where they've had improvement in actually complete resolution in hepatic hydrothorax. So the role of TIPS. There's several retrospective studies on the role of TIPS in patients with hepatic hydrothorax, and it's always as a bridge for transplant. And combining most of these studies over here, there's a total of about 300 patients, and what they looked into was the overall response, which is defined as whether it was complete resolution or partial resolution. Complete is defined when there's complete resolution of the hydrothorax based on the image finding. Partial is based on their symptoms and the fact that they don't require frequent thoracentesis. And the average, it was a wide range between 58 to 80% in these patients, and there was no difference in the complications. It was similar to any other patients that underwent TIPS, which included shunt dysfunction or hepatic encephalopathy. Liver transplant. There's this one study which was interesting where they looked into patients with hepatic hydrothorax and without hepatic hydrothorax that underwent liver transplant. There was 28 patients in those who had hepatic hydrothorax and about close to 50 those without. And interestingly, the post-op complications were no different in both the groups. Fluid pleural effusion can persist for a few months. However, none of them really required thoracentesis post-liver transplant. And even the days spent on mechanical ventilation was no different between the two groups. Prevent fluid transferring from the peritoneum to the pleural space. So as I said, paracentesis should be attempted in all these patients before performing a thoracentesis. In Europe, they're actually doing a phase 3 controlled trial on an alpha pump, which drains fluid in the peritoneum into the bladder, and they're still, I think they're not expected to finish this within the next, it's going to take another year or two before it starts, before they get more data on this. So draining the fluid. Repeated thoracentesis versus placing chest tubes. Now, it's controversial in terms of placing chest tubes in these patients because of the fact that they have high output and continuously drain, and when is a good time to pull it off? There was a study in chest in 2004 where they analyzed about 59 patients with cirrhosis, and 80% of them had several complications. Most of them included renal failure, electrolyte imbalance, infections. Some of them did undergo TIPS after placing the chest tube. Some of them underwent liver transplant, and some of them died with the chest tube in. And the way they separated them based on their child Pew risk, class B and class C. And the results are over here, and where it says the median days with the chest tube in place is 5. However, if you look at the ranges from 1 all the way to 53 days, the same applies for those with class C. The range was from 1 to 39 days. And most of these patients did die from bacteremia and sepsis, and there was probably 2 patients that had spontaneous bacterial empyema. So, indwelling catheters. There is, again, very limited data on placing indwelling catheters in patients with hepatic hydrothorax. If this were a sole purpose to get them extubated off a ventilator so that they can get transplanted, then chest tubes and Pleurex catheters can be considered. Otherwise, these are not generally recommended, especially there's no strong evidence to it. So VATS and pleurodesis, again, very limited data on these studies that's been done. There's one particular study that was done in Brazil where they had about 21 patients, and they did pleurodesis using talc. They had about a 47% success rate in these patients, and in 3 patients they had to go redo the procedure again in about 3 months. And most of these patients are pretty fragile to undergo such procedures, and It's not something that we usually do over here because as it is, their morbidity and their mortality is high to begin with. So I don't think even Jaspi believes on this. I found this on, there's a Japanese article where there was two patients where there was complete resolution with use of continuous positive airway pressure pressure support. Although it makes sense theoretically, even I wouldn't prescribe this. So a general overview and a summary in terms of treating these patients with hepatic hydrothorax. Diuresing them with diuretics, aldactone and furosemide. In patients who are refractory to diuretics and those that are candidates for liver transplant. Depends on the time period, and there's no strict guidelines on what to do here. But if it's less than 3 months, these are patients that can afford to get repeated thoracentesis. And that also depends on how rapidly the fluid is accumulating. If their wait is long to get transplant, TIPS is in consideration, and there's no strong recommendation in terms of getting pleurodesis done or a Pleurex catheter for those patients. So moving on to Hepatopulmonary Syndrome. So initially it was termed as a liver-induced vascular disorder of the lungs. So in 1884, Dr. Flukiger described this as patients with he noticed patients with hypoxia with cirrhosis and cyanosis and digital clubbing. Later on, they did autopsies on cirrhotic patients where they found that these patients had marked pulmonary vascular dilatation. And then eventually they put everything together and defined Hepatopulmonary Syndrome, which is defined as oxygenation defect caused by intrapulmonary vascular dilatation in patients with advanced liver disease. The prevalence, there's no prospective study, so the prevalence in patients who underwent liver transplant suggests it's ranged between 5 to 32%. The survival rate depends on how severe the hepatopulmonary syndrome is, which is defined on the PaO2, the oxygen content. The median survival rate for patients with hepatopulmonary syndrome is about 24 months, and the 5-year survival rate is 23%. These are in those patients who are not candidates for liver transplant. So the disorders that are associated with hepatopulmonary syndrome: any chronic liver disease, chronic hepatitis, primary biliary cirrhosis, alpha-1 antitrypsin deficiency, and so on. The pathobiology comes with a definition. There's gross dilatation of the precapillary and the capillary vessels, coupled with increase in number of dilated vessels. There's also noted to have pulmonary AV shunts in these patients. The way they derived the pathophysiology for these patients was actually based on studies they did on rats. They mimicked cirrhosis by dilating their common bile duct, and they noted that these patients had increased production of nitric oxide. And what happens is, when there is inflammation, there is production of endothelin-1, and this activates the nitric oxide synthetase, which results in increased production of nitric oxide in the monocytes, and also aggregates these monocytes to release VEGF, which is vascular endothelial growth factor, and that stimulates angiogenesis. This is just another flow chart showing the pathophysiology. And here's a better picture of what actually happens when compared to a normal alveoli. On the left, with the homogeneous lung, there's uniform ventilation and perfusion, whereas in hepatopulmonary syndrome, as you can see, the diameter of the capillary is significantly larger, and there is also a shunt through an AV malformation, which limits diffusion from the alveolus into the capillaries. And the normal diameter is about 8 to 15 micrometers, and in patients with hepatopulmonary syndrome, it can be as big as 100 micrometers. So clinical presentation, there is no specific signs or symptoms. However, when you have a patient with liver disorder, complaining of dyspnea at rest or exertion, and with concomitant hypoxia, these patients usually, if they have truly hepatopulmonary syndrome, they have platypnea and orthodeoxia, which basically is shortness of breath when they stand up from a lying position. And orthodeoxia is defined as a drop in the PO2 by 5% or 4 millimeters of mercury. If there is a patient with cirrhosis hypoxia that has a PO2 of less than 60 millimeters of mercury with no known pulmonary disorder, then it strongly suggests an underlying hepatopulmonary syndrome. So in order to diagnose patients with hepatopulmonary syndrome, we need an ABG to confirm hypoxemia, and it also helps determine how severe it is, which would help in their MELD exception points. Transthoracic echocardiograph with a bubble study would show extra presence of shunting, extracardiac delayed bubbles, particularly usually after 3 to 5 cycles. So there's also a radioactive lung perfusion study. This is not specific for, you can't differentiate whether the shunt is intracardiac or extracardiac. However, this can help quantify the severity of shunting if the patient does have hepatopulmonary syndrome. They basically inject macroaggregated albumin, which is labeled with technetium, into the veins, and they perform imaging of the lungs as well as the brain. Images A and B shows us normal uptake, and when there is a shunt, these albumin actually escape through the shunts, and they start to move downstream with the main vessels that's supplied by the systemic arteries. That's why they end up going to the brain and the kidneys and spleen. And anything more than 6% is considered as a positive shunt for HPS. Now, radiological studies of chest X-ray and HRCT are important in ruling out other pulmonary diseases. Usually they're normal in patients with hepatopulmonary syndrome, or they could be increased reticular markings or vascular markings in the lower zones. Diffusion capacities usually shows a reduced DLCO. Pulmonary angio is not done in all patients, but in those who we think do have AV communications, pulmonary angiography would be helpful in terms of treating them. So there's two types, type 1 and type 2. Type 1 is where we response to oxygen. There's diffuse spidery abnormalities in the peripheries. And type 2 is when you can actually visualize an AV malformation. Images A, B, and C show type 1. And in image A, you can see the medial basal segment of the left lung, where there's those fine spidery abnormalities. And image D is where we have the AVMs. So the diagnostic criteria, in order to diagnose them, on an ABG, you need a PO2 less than 80 or an AA gradient above 15. You should also demonstrate evidence of extracardiac shunting on an echocardiogram, and obviously these patients do have portal hypertension. The severity, it's mild when we only have an AA gradient that's more than 15 with a PO2 above 80. It's considered moderate when the PO2 is between 60 to 80, and when it's between 50 to 60, it's considered severe, and very severe if it's less than 50. This is just a screening algorithm. So if we have patients in the clinic who are hypoxic with known liver disease, and if we just do pulse oximetries, if they're less than 96%, then we can proceed with getting an echocardiogram, and if it does show evidence of pulmonary vasodilatation in the form of shunting, the next step would be to get an ABG. And if it fits the criteria for the ABG, where the AA gradient's more than 15, or if the PO2 is less than 80, making sure we exclude other pulmonary disorders, we can come to a conclusion this patient's probably got hepatopulmonary syndrome. Now, if the PO2 and the ABG has to be less than 60 in order for them to get those MELD exception points. And so usually I believe they start off with 22 points, and the more severe they get, when they get reevaluated every 3 months, they get 2 points get added on for their for them being on transplant list. So the treatment is supplemental oxygen. There's been a lot of other ridiculous studies that's been over there where they looked into. One thing I found interesting was garlic, because they're still doing active research on garlic because of the fact that garlic reduces nitric oxide production. Not sure how much science there is behind it, but I wish PJ was here because it's his colleagues in West Bengal that's actually involved in this study. This was a very old study where they followed about 40 patients with they supplemented them with these garlic pearls, which is about 1 milligram per meter squared per kilogram, and there was no statistical significance at all. The data didn't really make much change. But they're actually doing another study currently in India where they're looking into garlic as a treatment for hepatopulmonary syndrome. So what's the role of TIPS in hepatopulmonary syndrome? There's actually not much evidence that hepatopulmonary syndrome, TIPS is actually beneficial in hepatopulmonary syndrome. Theoretically, it can actually worsen it, where it can enhance pulmonary vasodilatation. In patients who have large AVMs, coiling can be done by IR to improve hypoxemia. So again, apart from oxygen, the only reversible treatment that's available is liver transplant. And until about 2000 to 2002, there were no MELD exception points for hepatopulmonary syndrome. So key important feature in these patients with hepatopulmonary syndrome, it may take up to a year and a half for the hypoxemia to resolve, but a post-operative hypoxemia, if there's refractory hypoxemia, which is the same severity as it was prior to transplant, indicates a poor prognosis in these patients. In those that have very severe hepatopulmonary syndrome, in a PO2 less than 50, the mortality is actually 7.5 higher than those with mild hepatopulmonary syndrome. That's it.
You mentioned in the slides that if the PO2 is more than 60, you're going to have to redraw ABGs every 6 months.
3 months.
Or 3 months. Okay, so it may progress or develop.
Yeah.
And that's in the presence of a shunt, correct? We have to have a
Yes.
shunt?
Yes.
Say it's too severe to transplant.
They can't
They don't. Okay.
really because it's the only cure. But they get nervous at a pH of less than 45. The thing that no one understands, usually they go into it, but the overlap between portopulmonary hypertension and hepatopulmonary syndrome, because for a long time everyone said you can't have both because the mechanisms are totally different. But there's almost an 80% overlap in patients who have portopulmonary who also have HPS. And it's odd because it's low nitric oxide and high endothelin, and then the opposite for the other disorder. So there's something that we don't understand about the mechanism.
Do they respond differently to prostacyclin therapy that you have to treat them for hypertension?
You have to worry about worsening hypoxemia with them the same way we sort of do with any shunt. Why the sad
You predicted I'll just me.